Right. Uh, a very good evening to all. At the very outset, many thanks to Team Apollo Ortho, in particular Dr. Agnish Tikku and Dr. Siddharth Yadav. I must acknowledge, appreciate, and thank them for this wonderful and noble work, especially during this tough time. I think it's a great contribution from them. My today's topic is approach to a septic arthritis management. It's a general approach. If there is a septic arthritis of any joint, how one should be approaching and what are the general broader treatment guidelines. It's not a specific to a particular joint. Uh, so why to worry about septic arthritis in the first instance? The reason for that is this is considered to be medical rather orthopedic emergency. Septic arthritis is an inflammation of the synovial membrane with purulent effusion into the joint. Sorry, into the joint capsule due to infection, and this is also referred to as infectious arthritis. Actually, septic arthritis is a key consideration in all adults presenting with acute monoarthritis. So, whenever an adult patient presenting with acute monoarthritis with severe pain, swelling, we have to consider septic arthritis as a diagnosis first, unless ruled otherwise. And if we are not able to treat it aggressively within 24 to 48 hours by drainage and by appropriate antibiotics, it can cause permanent dysfunction of the joint, especially by damaging the subchondral bone. And at times, it can be really fatal as well. So, we have to be careful that we manage it very aggressively. When we talk of septic arthritis, essentially we need to know the background that synovial membrane is highly vascular structure. The bacteria can easily enter the synovial joint via bloodstream. There will be inflammatory reaction with seropurulent exudate and increase in synovial fluid. And as this happens, there will be pus formation within the joint, and because of the pus formation, the articular cartilage get eroded and destroyed. And we all know that a hyaline cartilage, once it is destroyed, it's not going to be repaired, and exactly by similar way, it's not going to be. And then hence, there will be secondary changes. There will be osteoarthritis, secondary deformity. The joint get damaged, and permanent disability will happen. This happened partly by bacterial enzyme and partly by the enzyme released from the synovium and inflammatory cells and pus. Grossly, if you see the pathology, it's slightly different in different age group. When you talk of infant, it's slightly different. In children, it is different. In adult, it is different. Why it is so? Because in infant, the septic arthritis tend to destroy the epiphysis, which is still largely the cartilaginous. The whole epiphysis will be destroyed, and essentially the child will end up in just a pseudo arthrosis type of picture. So there won't be a proper joint afterwards. When you talk of children, there will be vascular occlusion, which can lead to necrosis of epiphyseal bone and hence, obviously, joint damage. When you talk of adult, it is mainly the articular cartilage which get eroded, and there will be damage to the articular cartilage and obviously dysfunction of the joint as per accordingly. So gradually, when the pus happens inside the joint, actually pus forms, the pus may not remain only inside the joint. It may burst open out of the joint to form abscesses and sinuses, and the joint may become pathological, dislocated, and hence obviously disability. If you look at this pictorial view, this is a normal joint with a normal cartilage with normal joint space. But look at here, there's a pus, the cartilage will be destroyed, and the whole joint will start getting damaged. Uh, it happens in stages also, although the stages don't take a lot of time to, like in it's compared to the tuberculosis. In tuberculosis, it takes a bit of time for stages to cross, whereas in septic arthritis, everything is quick. In early stage, there is acute synovitis with purulent joint effusion. Sooner the cartilage is going to be attacked by the bacterial and cellular enzyme, and if infection is not arrested or controlled at this stage, the whole cartilage will be completely destroyed and it will lead to healing by ankylosis. And mind you, it invariably leads to bony ankylosis as you see in this picture. Whereas if you could talk of tubercular arthritis, invariably it lead to fibrous ankylosis if it is not treated properly actually. You have to remember one thing as I alluded earlier also, the acute monoarthritis is septic until proved otherwise. So if you take away from this one slide, the couple, at least one of the message very important is any acute monoarthritis is septic arthritis unless until proved otherwise. So you have to rule out this first, and then only you should be labeling it as any other diagnosis. You also need to remind yourself that septic arthritis can be monoarticular, but not necessarily in 100% cases, in only 80 to 90%, whereas 10 to 20% cases tend to be oligoarticular or maybe polyarticular. So that is slightly, I mean, you need to be aware of this. Not necessarily all the polyarticular arthritis are non-infective. They can be infective, they can be septic as well. And especially when there's infection because of the gonococcal or meningococcal infection, they've got more tendency to be oligo or polyarticular. It can be acute presentation of a polyarticular disease which presents as monoarticular onset. So also need to be remembered like condition like rheumatoid arthritis, GRA, reactive or enteropathic arthritis, sarcoid arthritis, any viral arthritis or psoriatic arthropathy. They can present as a monoarticular or they can be presentation of a polyarticular but initially with a monoarticular arthritis. So what are the common signs? Do every joint can get infected because of infection? But the commonly like shoulder, you got hip, knee, and ankle, or maybe elbow. These are the joint affected. But knee is the leading in the incidence wise. And simultaneously, you must remember the polyarticular incidence is quite a significant as well. So you should be reminding yourself about that fact as well. So key point is the target is to distinguish articular from non-articular pathology, and if it is articular pathology, you must be able to distinguish it from monoarticular versus polyarticular arthritis. And most important is to differentiate septic versus non-septic arthritis. And if it is non-septic arthritis, you should be able to distinguish or differentiate inflammatory versus non-inflammatory disease. However, always consider septic arthritis as a diagnosis number one, exclude this and then label it otherwise. So when we talk of management or approach, what is the objective? Objective is to treat it, to restore the function of the joint to the normal or near normal if possible, if not normal. So what are prerequisite? Prerequisite, we need to have a complete diagnosis. We need to have an exact diagnosis. If our diagnosis is not correct, we will not be able to treat it. So, what is the prerequisite to have? What are the criteria to for a good complete diagnosis? A complete diagnosis would not be possible without a good history, thorough examination, and of course, the appropriate investigation or relevant investigation. And also, you need to exclude other differential diagnoses so that you can directly diagnose it as septic arthritis and, of course, treat it accordingly. So, before going further, we do need to know what can be the possible potential differential diagnosis so that accordingly, in right from the history, examination, and investigation, you start ruling out the differential diagnosis. The most common is osteomyelitis, reactive arthritis, crystal arthropathy. It can be because of trauma, fracture, or internal derangement. There can be cellulitis, bursitis, toxic and transient or transient synovitis, myositis, tumor, growing pain, rheumatic fever, and at times it may be infective but not necessarily pyogenic infection. There can be viral infection, fungal infection, or tubercular arthritis, and other rare conditions like hemarthrosis, osteonecrosis, or presentation of acute polyarticular disease, as I've already told you. So, most important, you also need to remind yourself by this time, everybody has more or less many topics have been covered, and the most important emphasis, especially for PG teaching and even for the lifelong, is history. History, you obviously start chronologically like introduction, age, gender, onset, duration, progression, site, severity, diurnal variation, aggravating, relieving factors, associated fever, limitation of function, i.e., whether patient is able to walk or not, whether a patient is able to use a particular limb or joint or not. Very important. But it has to be very careful, methodical history because history can give you 70% of the diagnosis. And if you're not careful, you would miss. You obviously have to ask for the constitutional symptoms. It can be associated with fatigue, nausea, malaise, loss of appetite, and also rarely they can be associated rashes. In case of gonococcal arthritis, sexual history is important, and also don't forget to ask for bladder and bowel habits. As the disease is going to progress, the infection is progressing, the joint becomes swollen and red. There can be picture of pseudo paralysis, especially in children, and there will be extremely reduced painful range of motion. And usually there is a history of maybe recent history of trivial trauma. Mind you, it's a exactly mechanism of injury. You have to ask the patient, and parents are going to present that the patient had a history of injury, but what kind of injury you have to ask, whether it's a trivial injury or significant injury. If it is a trivial injury and followed by that there's swelling, infection after a few days, that means it is septic arthritis, unless proved otherwise. You also need to obviously in children ask for a history of immunization in case of in history of any globulopathies, exposure, any abnormal exposure like to animals, farm, travel to TB endemic area. And those conditions, you will have a rare infection like Bartonella, Brucella, tuberculosis, or coccidiosis, and also need to ask for history of any past history of MRSA infection or maybe contact. Simultaneously, in the history, one must be careful to rule out any predisposing factor or any risk factors for septic arthritis. Like risk factors can be rheumatoid arthritis, osteoarthritis, prosthetic joint, previously low in socioeconomic status, IV drug abuser, history of alcoholism, diabetes, previous intraarticular corticosteroid injection, any history of cutaneous ulcer in and around the limb, joint, or in the limb. History will obviously tell us to differentiate septic arthritis compared to other condition, like pain comes suddenly in minutes after any fracture when there is significant trauma, over several hours, maybe or maybe 1 to 2 days in case of infection, crystal arthropathy or inflammatory arthropathy. There may be history of IV drug abuse or recent infection and likely diagnosis to be septic unless proved otherwise. You must ask for history of previous similar attack. If that is the case, is the most suggestive of crystal arthropathy or inflammatory arthropathy. Ask for a history of any prolonged course of steroid, and that obviously infection is one of the. This can be predisposing factor for infection or maybe osteonecrosis of the bone. So you have to careful ask for complete history. Once you have the complete history, of course, you need to ask the past medical history, the comorbidities, and everything. You have to tick boxes, all the history as you would do in any case for that matter. And then you switch on to the physical examination, which is the key component. Uh, uh, you have to examine the similar sequence: look, feel, move, and which essentially mean inspection, palpation, and range of motion, and then adjacent joint, contralateral limb, contralateral joint, and any special test for that matter. You have to do again all the tick boxes. In case of septic arthritis in particular, the lower limb there will be intelligent, rather patient will not be able to walk at all. The patient will not be able to put any weight whatsoever on the lower limb, and in upper limb will not be able to use upper limb. It's going to be closely guarded. There will be marked tenderness. There will be local rise of temperature. Active and passive range of motion is extremely limited or not possible at all. Extremely painful. The child or adult is going to start screaming the moment you are going to move. However, there can be exceptions as well. Examination of synovial, there will be a fusion, of course, erythema. There is a local rise of temperature, tenderness, spasm of the muscle around the joint, and patient may hold the joint in a position to reduce the intraarticular pressure to the minimize the pain. This is called the position of comfort. This is an example of septic arthritis, red heart, swollen knee joint. Position of comfort is basically position of maximum capsule volume there where the patient the joint can accommodate the fluid. So the patient is going to keep that joint into that orientation to minimize pain. For example, knee, ankle, and elbow are going to be partially flexed, whereas the shoulder is going to be abducted and internally rotated. In case of hip, it's going to be flexed, externally rotated, and abducted. Whereas because hip being the deep joint, there won't be any obvious swelling. So you have to be careful about that. This is an example, the child obviously keeping in that particular posture, and septic arthritis actually is the diagnosis. There will be this you have to remember, there will be decreased or absent range of motion, and they are extremely painful. So that is one of the key pathognomic feature of septic arthritis. Another example, red heart, patient febrile. So these are then another example, the child irritable, warm, tenderness, rapid pulse, refused feeding, and loss of spontaneous movement of the extremity. Again, not able to bear weight, febrile child, and obviously you're going to ask for relevant blood investigation. An example of asymmetric inflammatory oligoarthritis, not septic arthritis. An example of acute gouty arthritis, and it is an example of disseminated gonococcal pustules. So, because these are differential diagnoses, so one need to be aware of those things. Also, you need to know that the clinical manifestation can be slightly different in different age groups, like in newborn patient and in the children and adult. Like newborn, there will be more of septicemia rather than giant pain. Obviously, child is not going to be able to express as well. The baby is going to be irritable and refuse to feed. There will be tachycardia with fever. Giant is going to be warm. There will be tenderness and resistant to movement. And you must examine. Don't forget to examine umbilical cord or any IV site if there is inflammation or not. That can be suspicious source of infection. Whereas in children, in acute pain in single large joint, especially the hip, the picture of pseudo paralysis, child will be ill, rapid pulse, swinging fever, overlying skin will look hard, red, will look red. The superficial joint is going to be swollen. There will be local rise of temperature. Of course, there will be tenderness, and all the movements are going to be extremely painful. And look for the source of infection in the vicinity. Whereas in case of adult, often the superficial joint like knee, wrist, and ankle is involved, joint painful, swollen, inflamed, a similar picture as the children. Local rise of temperature, marked tenderness, range of motion restricted. Look for gonococcal infection or drug abuse. Patients with rheumatoid arthritis, and especially those on corticosteroid, may develop silent joint infection, not necessarily going to have a heart giant, not necessarily going to have a acute picture like as in classical septic arthritis. You need to be aware of that. Those patients who are immunosuppressed, they are immunely compromised on immunosuppressant, they will not be able to present with a similar picture. And simultaneously, don't forget to examine the patient, general physical examination, systemic examination, and of course, very, very important, the vitals. So you have to tick all the boxes systematically, especially the vital. There may be pulse, tachycardia, respirate towards the later stage can be decreased. Saturation can be slightly altered, especially in patient goes in septicemia, but most important, of course, the fever. In summary, and the clinical examination or history, there will be red, hot, painful joint with fever, erythema, severe pain, severe marked swelling of the joint, severe tenderness, local rise of temperature, and of course, severely limited painful range of motion. So once history and examination is done, the next in line to establish diagnosis is, of course, the investigation. So grossly, what are the investigation? Again, they're divided to three groups. There are blood investigation, there are imaging, and there will be synovial fluid analysis. This is what generally in septic arthritis you do. So to remember when to ask what for, more or less everything is required. In investigation, you start with a complete blood count, simple investigation. There will invariably raise WBC, ESR, though it happens in chronic infection, but can be elevated here and more so helpful in monitoring as well. If it is more than 40 millimeter, CRP, very, very helpful, very sensitive investigation. Don't undermine the importance of CRP, uh, to especially for diagnosis as well as monitoring of the patient. If CRP is more than 20, that if it is less than 20, less likely it is septic. However, there can be exception as well. There is also something called as qualitative CRP, which means positive or negative. Normally, you should not be asking for that, but if it is negative CRP, that invariably rule out septic arthritis. Having said that, there can be exception rarely as well. Whereas CRP high, positive does not mean much. Positive can be 10, positive can be 20 as well. But in the severe infection, positive can be 100 as well. So you have to rely on quantitative CRP rather than qualitative CRP. And if child is septic, you have to ask for blood culture as well, and which may be positive. Of course, you have to ask for other investigation routine like blood sugar because blood group because the child may need blood transfusion or adult LFT or FT depending upon the circumstances and any comorbidities for that matter. But invariably, you should be asking for this basic routine investigation. One to have the baseline, two to rule out like any predisposing abnormality in this, so that you can give the drugs appropriately, and of course, subsequently you can monitor them. However, absence of increased WBC Absence of increased CRP or ESR does not exclude septic arthritis, but these are helpful in monitoring the treatment. Rarely, other tests can be asked for, like coagulation profile, whenever there is a history suggestive of any uh, abnormal bleeding tendency. Rarely indicated serological tests like ANA, rheumatoid factor, or serum uric acid level. Next would be, because we finished the blood, you are talking of investigation, you got an investigation, you got a blood investigation, you got imaging, and you got synovial fluid analysis. Imaging, though no robust optimal imaging which can diagnose septic arthritis, however, plain radiography is a must and routinely should be asked for. In early stage, the X-ray is going to be invariably normal, but you have to look for soft tissue swelling, loss of soft tissue plane. There will be widening of joint space, and there can be slight subluxation due to fluid in the joint. And at time, really, there can be gas, especially if the infection is because of E. coli. In the late stage, however, there will be narrowing and irregularity of the joint space, and at times the plain film also can be have a picture of superimposed osteomyelitis, which will develop the periosteal reaction, bone destruction, and subsequent sequestration formation. That is also very important, that it will help to some extent to rule out osteomyelitis, which can be associated with septic arthritis or primarily septic arthritis. Subsequently, septic arthritis can happen after primary osteomyelitis. There can be erosion of the joint or articular surface. Look at the picture. On the left side, there's a widening of joint space and there is a subluxation initial stage. Another example, joint is externally rotated flexed, and also there's a slight subluxation, the widening of the joint space actually there. Not clear picture, but suggestive of widening joint. The next investigation and imaging is ultrasonography. It is very sensitive in detecting the giant effusion generated by the septic arthritis. One of the very important tools so far as imaging is concerned, especially for the deeper joint. Ultrasound can be used to define the extent of septic arthritis and help also us in the guided aspiration. Ultrasound help us to differentiate septic arthritis from other conditions like soft tissue abscesses, tenosynovitis, in which the treatment may differ completely. It is more reliable imaging in a giant effusion. In earliest cases, there will be widening of the space between the capsule and the bone of more than 2 millimeter, which obviously indicates effusion. In case of transient synovitis, if the ultrasound, the problem with ultrasonography is you need to have a good ultrasonologist. It's just not a machine dependent. It is mainly the man behind the machine is going to differentiate or pick it up. In transient synovitis, generally the echogenicity, there won't be any echogenicity, whereas there will be positive echogenicity in case of septic arthritis. So this is very important actually. If you've got lucky enough to have a good backup of radiologist, ultrasоnologist, he or she can really help you in differentiating these conditions. Very much helpful in case of the deeper joint like hip, as I already told you. Just an example, this is a normal joint fluid, not much actually, normal joint space, anechoic and concave shape. Whereas here, there is increased joint effusion, there is increased size, and becomes convex. CT scan, though rarely indicated insofar as septic arthritis diagnosis is concerned, uh, it can be helpful for detection of associated osteomyelitis, though rarely asked for, and at times deeper giant, difficult giant like sternoclavicular, sacroiliac, or, for example, rarely in the spine, say cervico-dorsal junction or lumbosacral junction. If there is a problem pathology, the CT can be helpful. MRI, though, is slightly more frequently asked for and useful in detection of pyogenic sacroiliitis, spread of infection to adjacent joint. MRI is most useful in assessing the presence of periarticular osteomyelitis as a causative mechanism as well. Rarely, one has to ask for radioisotope bone scan. It will show increased uptake of isotope in the region of joint and may help in difficult joints like sacroiliac or sternoclavicular joint. Can be helpful also in case of polyarticular or oligoarticular involvement. Scintigraphy can help us to differentiate septic from osteoarthritis, but not from other cause of inflammation, because invariably the uptake is going to be same. So you have to be careful. It perhaps can differentiate osteoarthritis from septic arthritis, but not from other causes of inflammatory arthropathy. The next investigation modality is obviously to establish diagnosis is synovial fluid analysis. It is essential in the diagnosis of septic arthritis. But be careful, it has to be done under all aseptic precaution and it should be used to aspirate the joint. Avoid taking from the infected site because you are going to otherwise introduce infection if it was never there inside. The fluid must be analyzed for gross examination and microscopic examination, and of course should be sent for culture sensitivity. The fluid has to be examined for just appearance, how it is appearing. Is it like turbid, it is pus, or is it normal fluid, just like a straw colored? Any appearance, what is the volume, how much you have aspirated, what is viscosity, and what is mucin, clotting like that. And microscopic examinations must include leukocyte count and gram staining, very, very important, serum glucose ratio with the synovial fluid and the amount of protein. And finally, of course, don't forget to send it for the culture sensitivity. Very important, actually. Always use a wide bore needle when you suspect infection, as pus may be viscous and difficult to aspirate. Inoculation of synovial fluid into the blood culture bottle can improve the positive yield of culture. However, it should not be done at the bedside. PCR does not have any advantage except in cases of Borrelia. Crystal examination should be part of the examination as a routine. Just an example of the knee joint aspiration, you invariably done in the parapatellar region, like it slightly flex up to the 15-degree, and you should be, if you are entering from medial side, you are entering in 2 to 3 o'clock position. From lateral entry, it should be 9 to 10 o'clock position, and insert the needle perpendicular to the knee joint, not vertical. Okay, this is an example. The thick pus is coming. Obviously, the diagnosis is very straightforward. Actually, it is septic arthritis unless proved otherwise. Straw colored fluid can be septic still. We have to examine. It can't be ruled out just by the color. An example of hip joint, anterior approach. Of course, it has to be draped, everything sterile. It should not be undraped, properly prepared as you would do it for any procedure actually. Like in theater condition, patients, there are two approaches to hip joint, anterior approach and lateral approach. Anterior approach just 1 inch lateral to the femoral artery and 1 inch inferior to the inguinal ligament. In the lateral approach, palpate the greater trochanter, needle is inserted just anterior to the tip of the greater trochanter, parallel to the coach and inclined at 45-degree cephalad. Ankle, the patient is supine, ankle is 90-degree and just medial to the tibialis anterior tendon, palpable dimple, which is the point of the needle insertion. In the shoulder joint, invariably from posterior approach, insert the needle 1 to 2 centimeters inferior to the acromion, just medial to the humeral head, and angle the needle slightly medial in the horizontal plane. In the elbow joint, again on the lateral approach, flex the elbow to 90-degree, prepare the skin, insert the needle in a palpable bony notch between the lateral epicondyle and the olecranon. There's a small triangle type dip and where you have to insert the needle in palpable. In the wrist joint, wrist is kept in neutral in line with the forearm. Palpate a dimple overlying the radiocarpal joint and insert the needle perpendicular to the limb. The next step would be you have to analyze microscopically, and the cell count invariably in septic arthritis is going to more than 50,000. And out of that, 75% are going to be neutrophil. The glucose level is going to be low as compared to the blood. The gram staining, relative insensitive, but must to ask for, and can be positive only in 50% cases, not necessarily all the cases. Culture, however, is more sensitive, but again, may not be positive in 100% cases, but more sensitive and always should be asked for. Mind you, the most important is before starting investigation, before starting antibiotic, you must aspirate. That's the first and foremost. I will be again repeating this as well. The takeaway from this is you must analyze, take out the fluid specimen before injecting antibiotic. The moment you inject the antibiotic, the whole purpose get lost. So you have to be very careful. You got like synovial fluid can grossly tell you actually quite a few things. Like normal giant is going to have less than 150 WBC, non-inflammatory, inflammatory arthropathy, septic arthritis involving, I already told you more than 50,000, and in case of hemorrhagic, similar to the blood. Also, you need to analyze the color, the viscosity, and other stuff actually. However, the crystal examination should be a routine workup when case of septic arthritis, especially after aspirating the synovial fluid. Invariably, the urate crystal, typical the gouty arthritis is going to present with the needle-shaped crystal, and they are strongly negative birefringent. Whereas in case of pseudogout, the rod-shaped or rhomboid-shaped and the weakly positive birefringent. When to ask for special culture? At time you have to ask for special culture of the synovial fluid when there is a history of tuberculosis exposure, history of penetrating trauma, animal bite, or patient live in or have traveled to endemic site for borrelia or fungal infection. And if the patient is immunocompromised and if the patient is not responding to conventional appropriate treatment. Blood culture, especially in patient is septic, can be positive in 40% of cases. And rarely especially when you talk suspecting gonococcal infection, you may have to ask for culture from cervix, urethra, throat, rectum, skin lesion also. Just like algorithm, you have to take a complete history and examination. If there is a history of trauma or focal bone pain, ask for X-ray. If there is a fracture or avulsion, there can be osteoarthritis or osteochondrocalcinosis. Rule out soft tissue problem around the joint. That's very important. Obviously, you're going to ask for CBC, ESR, CRP. So, investigation wise, after history and examination, X-ray and uh, routine blood like CBC, ESR, CRP, very important. And if there is a giant effusion or inflammation, go for arthrocentesis, i.e., synovial fluid analysis. If there is no effusion but giant pain, severe symptoms, ask for CT, MRI, or ultrasonography, routinely ultrasonography, particularly for the deeper giant, but MRI is quite helpful as well. So this is a brief algorithm when you talk of arthrocentesis, because this is a very important investigation. So, for a septic arthritis is concerned, you have to examine for crystals, and if there is a crystalline arthritis, obviously you treat it. Anti-inflammatory strong painkiller. WBC count less than 2000, invariably it is a non-inflammatory condition like osteoarthritis or internal derangement. More than 2000 can be inflammatory arthritis, and if it is more than 100,000 or 50,000 septic arthritis, unless proved otherwise, obviously you need to drain and appropriate antibiotics. Uh, if it is the fluid is bloody or blood like occult fracture or internal derangement or maybe tumor, and patient will have to ask for further investigation, arthroscopy or biopsy. If there is a fat droplet, large fat droplet, that means there can be fracture. So you need to be grossly having an idea, because invariably the septic arthritis is going to present with pain and swelling, and there are multiple differential diagnoses so far as that condition is concerned. Hence, you need to be oriented. You need to be aware what are the various investigation, how to differentiate these conditions. In hip giant septic arthritis, there is something like called as Cocker's criteria, and this can be independent predictor that may be used in the diagnosis of septic arthritis. Like patient will be refused to bear weight, unable to bear weight on the lower limb, of course. There will be patient will be febrile more than 38.5, WBC count more than 12,000, ESR more than 40. If CRP is less than 10, there is a negative predictor value of 87%. And if it is more than 20, along with this feature, the positive predictive value can be 85%. There's another criteria called by Newman, which says if you can have one of the 4 points is met, then invariably septic arthritis, like isolation of organism from an infected joint, isolation of organism from another source of with concomitant swollen and hard joint, or in synovial fluid analysis, there will be increased WBC count, increased ESR, CRP. Along with this, local temperature, patient is febrile, increased CRP. Imaging studies are used to rule out other conditions, and rarely blood culture can be asked. The third point is clinical feature and turbid giant fluid in the presence of previous antibiotic therapy, and when there is a histological or radiological evidence consistent with septic arthritis. So one of these points, if this is present, that is septic arthritis unless proved otherwise, as per the Newman criteria. So far, once the diagnosis, we try to establish the diagnosis. Once the diagnosis is made, however, unfortunately, the optimal management of septic arthritis is subject to considerable debate. There are no clear-cut guidelines for everything. What is the purpose actually? Purpose is to remove, when we are talking about treatment, the purpose is to removal of the purulent material, to a thorough washout, IV antibiotic. Don't forget the joint need appropriate rest, i.e. maybe in the form of traction or a slab or splint. And of course, never ever forget to use appropriate analgesia with adequate dose. And of course, there is a role of anti-inflammatory drug. It is just not a paracetamol is good enough. You need to have NSAID along with that, but most important, appropriate dose and duration. The first priority, however, is to aspirate the joint. I reiterate here, if one takeaway, the first takeaway was any monoarticular swollen painful joint is septic unless proved otherwise. Second takeaway is the aspirate the joint before start of IV antibiotic. Send for examination and then start simultaneously with the treatment. Of course, don't forget analgesia and sprintage, are already told, and should be done in the position of maximum comfort to alleviate the pain. The fluid replacement, and don't forget about the general condition of patient. This patient can be in shock or not able to eat or drink. So fluid replacement and nutrition support is important as well. The removal of pus is the key. However, the method remains controversial. It can be closed needle aspiration, it can be arthroscopic drainage, or it can be open arthrotomy. The goal is to decompress the joint, get the sterilization of the joint, and removal of all inflammatory debris. Especially in the hip joint, pyogenic arthritis requires prompt surgical drainage and irrigation. Open drainage of other joint may not be indicated as per the literature, but you should have a very low threshold of going ahead with drainage, wash out thoroughly, and then start and simultaneously start with antibiotic. Septic arthritis need intervention. This you have to take the third takeaway. Invariably, it needs. It's just not the antibiotics are not good enough, because invariably at times from many clinicians, especially general physician or non-orthopedic surgeon, they start with antibiotic, and unfortunately that ruin the picture whole, because you will not be able to isolate the organism the moment you already inject. And the most important way to treat is to get the organism and to get the sensitivity, which organism is going to be sensitive to a particular antibiotic. Otherwise, you start injecting loads of antibiotic left and right, and the person is not going to respond. Various studies have, however, advocated the needle aspiration initially, but in the deeper joint like hip arthrotomy is better. I think it's invariably in the superficial joint also. You should have a very low threshold of going ahead with arthrotomy, or mostly arthroscopic washer is preferable if you got the facilities and skill to do that. You should not be just putting a scope and causing more damage to the joint also. You need to be careful. Arthroscopic drainage, wherever possible, is preferred over arthrotomy, but mind you, again, you need good skills. You should not be just pushing and hitting with the cannulas and trocars, because can really lead to more damage. Repeat in the literature, it suggests that repeated joint tap, maybe 2 to 3 times a day, may be necessary during initial days. If frequent tap is required, proceed to arthrotomy. Arthrotomy is also indicated where there is adjacent joint tissue infection. However, the gonococcal infection rarely requires surgical drainage. You need to remember that. If appropriate choice of antibiotic and vigorous percutaneous drainage fails to clear the infection within after 5 to 7 days, obviously have to proceed for open arthrotomy. In case of arthroscopic, it's preferable to add limit synovectomy. So one should be able to use shaver as well, and resection of adhesion and removal of hard debris and loose bone and cartilage should be removed. And thorough washout, of course, has to be done. Don't ever forget about to resend the sample for culture, even if you already aspirated. And also, tissue should be sent for histopathological examination as well, because that's going to have differentiating from any other condition. For example, at time maybe tuberculosis or any other condition. So this is the best chance you can have a tissue to send it for histopathology as well. Have a very low threshold of repeated washout. This is not a one-off procedure that once you have done the washout and everything is going to be all right. It also depends upon the response to the clinical response, the markers, and especially the clinical response. If the patient not responding, again febrile, swollen joint, painful, have a low threshold of repeated washout, maybe once, twice, or thrice. Next is, of course, the antibiotic. We talked about the drainage, which is most important, but of course, not without antibiotics. But antibiotics should not be started before aspirating, before taking the sample. The moment you take sample, then you can start immediately. However, there is a little evidence exists about the choice, duration, and the route of antibiotic. Antibiotic, however, should be started empirically, should be based on the likelihood of organism in a particular area, and modified based on the culture sensitivity. The demographic factors and the risk factors will be predicted for atypical organism should be taken into the consideration. For gram positive, generally it is flucloxacin, unfortunately not routinely available in India. In West, it is the antibiotic of choice. Whereas in doubt, third generation cephalosporin in India, more or less we are using cephalosporin second or third generation, which will cover gram positive and gram negative organism. In case of children less than 4 years, it should be treated with ampicillin. Once the bacterial sensitivity, of course, is known, you must appropriately start that antibiotic. Finally, don't forget to treat the other foci of infection. Any coexisting medical condition has to be optimized and treated appropriately. And again, there is a role of NSAID already told are primarily they are therapeutic agent for reactive arthritis, but they have got significant role in septic arthritis because there is an inflammatory component which has to be subsided. But it is going to help faster recovery and of course the rehabilitation as well. Of course, this patient has to be observed, monitoring. This is not a one-off procedure. You've done the surgery and off you go. Patient has to be monitored for the fever, pain, general well-being, all the vitals including temperature, pulse, respiratory rate, saturation, input, output, patient web, serial CBC, CRP, particularly CBC, CRP, very important. ESR may not be that sensitive. So chase and act and then silently don't forget to put just culture has been sent and you ignore that. That doesn't happen. You have to chase it, liaise with the microbiologist, and act upon the sensitivity. In case of gonococcal infection, invariably ceftriaxone is sufficient. Gonococcal infection should also be treated receiving concurrent therapy for chlamydia, such as one dose of 2 gram azithromycin or 7 dose of doxycycline 100 milligram twice a day. In the native joint infection, antibiotic usually needed to be administered parenterally for at least minimum 2 weeks. However, 2 weeks is not the cutoff mark. It also depends on the response of the patient, the marker level, and then take it from there. Infection with either MRSA or MSSA requires at least 4 weeks of IV antibiotic therapy. MRSA should be treated by vancomycin 2 gram daily are obviously, but they have to. This is a very toxic drug. You have to monitor the level also an RFT and be sensitive about that. Oral antibiotic is almost never indicated in case of MRSA, MSSA, and prosthetic joint infection, whereas rifampicin, however, can be added, but this is not a only antibiotic. Should not be the only antibiotic because rifampicin has got the unique ability to penetrate the biofilm, but should not be used alone. The gram-negative native joint infection with a pathogen that is sensitive to quinolone can be treated with oral ciprofloxacin for the final 1 to 2 weeks of the treatment. As a rule, 2 weeks of course of IV antibiotics is sufficient for gonococcal arthritis, as already told and reiterated by the literature. If there is no expected response, if after 5 days of appropriate treatment, i.e., drainage, and IV antibiotic, then you must consider use of anti-inflammatory drug again if it is not been given in appropriate dose. Reculture the fluid and re-examine for crystal. Ask for serology for Lyme disease. If there is a suspicion of tuberculosis or fungal infection, you'd have to take biopsy and perform further imaging like X-rays. Repeat X-ray may be asked for. Repeat MRI has to be asked for. Scintigraphy to rule out periarticular osteomyelitis. Because again, the picture gets changing. It's not the one investigation. You ask for initial X-ray, and after that, you are going to not ask for repeat X-ray. Once, however, once hopefully you have treated the infection settled down. Don't forget that this is the condition pathology of the joint, and they become stiff if you don't act on afterwards as well. You need to start restoring. It's not a question of just treating the condition, the infection. Idea is, as I told in the beginning, to restore the joint to the normal. So you need to patient need to have aggressive physiotherapy. The primary aim of physiotherapy is to reduce pain, to restore and maintain the physiological function, and patient education about exercise and managing of their condition is must. Attempt not only just exercises, other modalities like electrotherapy, ice therapy, hydrotherapy, heat, TENS, IFT, ultrasound to manage the pain and joint stiffness. Note, the heat modalities are not supposed to be used in acute phase or before initiation of antibiotics. Whenever there is a healing, of course, after treatment, so what are the consequences can be? If the child is lucky or the patient is lucky, if you as a treating surgeon more aggressive, sensitive, and you've analyzed, anticipated everything, detected it, then there can be complete resolution and return to the normal function. Other scenario can be partial loss of cartilage and fibrosis. Third worst scenario can be bone ankylosing complete, and another scenario can be bone destruction and permanent bone deformity, dislocation, and subluxation. So, what are the complications? Any disease, any process? Why we are particularly, first of all, very worried about this problem is there can be dislocation. A tense effusion may lead to cause dislocation. There can be epiphyseal destruction. In neglected infant, septic arthritis is largely because epiphysis is cartilaginous. It will be completely destroyed and leaving with unstable pseudoarthrosis type of picture. And there can be growth disturbance because there's a growing children invariably involved. There can be physeal damage which can result into deformity or shortening of the limb. Ankylosis, already I told you, if articular cartilage is eroded, this may heal by bony ankylosis and not the fibrous ankylosis. There can be secondary osteoarthritis, especially in case of adults, and the infection can also spread to the surrounding areas like osteomyelitis and abscess formation. And also, don't forget, this child, the patient can become septic. They can go into septic shock, and mortality is a reality as well. It's not a rare. This is an example. The hip joint is destroyed, not treated appropriate stage, late disease. The second, metatarsophalangeal joint, completely destroyed, septic arthritis of ankle, leading subsequent on to the damage of the erosion, deformation, septic arthritis of knee and hip, subsequently AVN, secondary osteoarthritis, and other stuff. So, what is the prognosis? The best outcome of individual with a septic arthritis is immediate treatment. Mortality can range somewhere to 10 to 20%, though the here it suggests figure is slightly more, but the permanent joint disability can occur in 25 to 50% of cases. 50% of the adults with septic arthritis have significant decreased range of motion and chronic pain after infection, i.e., they will never be able to return to the normal function. Simultaneously, very important to have some insight about the differential diagnosis and how to differentiate. Most important condition is osteomyelitis near the joint may be almost indistinguishable from septic arthritis, and the safest is to assume that both are there. It can be acute hemarthrosis, either post-traumatic or due to hemophilic bleed, can closely resemble infection. The history is going to be very important in these cases, and of course, the joint aspirate will help to resolve the issue. The crystal arthropathy, both gout and pseudogout in adult, aspirate fluid may look turbid, but presence of urate and pyrophosphate crystal will perhaps confirm the diagnosis. Toxic or transient synovitis, it is essentially a diagnosis of exclusion. It is a benign inflammation which is generally self-limited, and there may be invariably history of recent past upper respiratory tract infection, and this condition generally tend to last for few weeks, maybe up to 4 months at times. I'm sorry that in recent past there is history of upper respiratory tract infection can be up to recent past like weeks to 4 months, and these symptoms are of this condition are generally less as compared to septic arthritis. Generally, tend to resolve within 7 to 10 days, and boys are generally more involved between the age of 3 to 10, most commonly affected. NSAID and the rest shorten the duration of the treatment. Pyomyositis is another condition. Most commonly, the musculature around the hip joint and thigh are involved, make the differentiation from the septic arthritis of the hip challenging. Psoas abscess is more pain with a rotation and hip extension. Septic arthritis of hip is more pain with a rotation when hip is flexed. MRI is best test to differentiate it. Lastly, just few question about the viva or theory. Uh, it can be infection can be because most common route is hematogenous, but it can be direct spread from adjacent local focal infection or maybe direct inoculation. When you talk of direct inoculation may result from penetrating trauma, it can be because of introduction of organism during the diagnostic or surgical procedure, for example, arthroscopy or intra-articular injection. When you talk of direct spread from the surrounding tissue, like more commonly in the children, like surrounding condition like osteomyelitis in the metaphyseal region from which it breaks through the periosteum into the joint. You also need to have a slight knowledge about epidemiology. The prevalence of the bacterial arthritis as a diagnosis among the adult is almost 8 to 27%. All the age group can affect it. No age group is immune to this. However, 50% of the cases are less than age 3. Male and female incidence is equal. The knee is, however, most commonly involved. When we talk of what are the organisms, that also depends upon the which age group. Though Staph aureus is most common in neonates, Streptococcus and gram-negative organisms are slightly more common. In infant, Staph aureus and H influenza. In children, Staph aureus and Salmonella. In adolescent, it is Staph aureus and gonococcal infection. In case of adult, Staph aureus, Streptococcus, gram-negative organism. And in case of IV drug abuser, invariably suspect Pseudomonas and atypical organism. Staph aureus and Streptococcus accounts for almost 91% of the cases. Gram-negative organisms are more common in older patient and immunocompromised patient. Anaerobic organisms are rare but more common when there is a history of penetrating trauma. Staph aureus in every age it can infect. H influenza invariably it is 6 months to 5 years. Gonococcal infection more than 10 years and mostly in adults. In case of gram negative is more common in case of immunodeficient, UTI patient, intestinal invasive procedure in recent past, elderly patient, any patient with a renal failure or chronic joint disorder, diabetes. Staph epidermidis, prosthetic joint infection, pseudomonas, IV drug abuser, uh, pneumonia, this uh, more common like listeria is in immune deficiency, and atypical mycobacteria are more common in chronic infection. There can be rarely infection because of the odd organisms like Lyme disease, listeria, mycobacteria, tuberculosis, tuberculosis, candida, rubella, any viral or fungal infection. So, in summary, heart swollen joint is a common medical emergency with a wide differential diagnosis. The most serious of these is septic arthritis. The diagnosis of septic arthritis can be difficult to make even in the hands of experienced clinician. Acute monoarthritis is septic arthritis unless proved otherwise. Irreversible joint destruction and disability can happen in case of delayed or no treatment, and mortality can be up to 11% of the cases. Hence, the early diagnosis and prompt treatment is very, very important. Optimal management is still a subject of considerable debate. Not much good quality evidence exists about the diagnosis and the management. No investigation is more reliable than examination by an experienced clinician. Absence of fever and raised WBC CRP does not exclude septic arthritis, and synovial fluid examination is a must. In algorithm management, septic arthritis, whenever is suspected, you must examine, send blood and synovial fluid sample, ask for X-ray, routine, AP lateral of a particular joint. Start with empirical antibiotics, but only after taking synovial fluids. And based on the organism sensitivity, you obviously change the antibiotic. And of course, you have to go for giant drainage because this is a surgical emergency, not just a medical emergency, and adjust the antibiotic based on the culture sensitivity result. Choose appropriate empirical antibiotic based and then changes as per the culture sensitivity. Consider unusual pathogens in immunocompromised patients. Note data to indicate for how long and for which route of antibiotic is preferable. Do not stop antibiotic till the signs and symptoms resolve and till the CBC, CRP, ESR return to the normal level. So take home message, please do not start antibiotic prior to arthrocentesis. Patient must be examined by the senior most available clinician. When in doubt, treat it as a septic arthritis unless proved otherwise. observe, and monitor. Thank you.